vibe, we shine on the light. We all over the world, chat night Africa. We all over the world, chat night Africa. Welcome to chat night, we bring you good vibe, we shine on the light. Welcome to chat night, we bring you good vibe, we shine on the light. We all over the world, chat night Africa. We all over the world, chat night Africa. Welcome to chat night, the only place that we give you good vibe. Chat night Africa.
Chat night Africa. Let's gang up, change mindset, and empower Africans. Are you ready? Africa to the world.
And now, live from the headquarters of Chat Night Africa, Divine Champion.
Hello, everyone. Thank you for coming to spend part of your evening with us. I'm your flight captain, Divine Chamukom. On Voices of Africa this week, bariatric surgery, a medical necessity or cosmetic procedure. My guest has seen it all. World-class surgeon Professor Mathias Fobi is a loud voice in the area of weight loss surgery. He is here with us. Ladies and gentlemen, join me now in welcoming Professor Mathias Fobi on the platform.
Thank you.
Professor Mathias Fobi, lots of women have been asking me to go after you, to come for you, to come grab you, to come on Voices of Africa at Chat Night. Thank you, sir, for accepting our invitation.
Thank you. I'm honored to be your guest, and I hope I can shed some light on this topic.
This week, as I said earlier, we're talking about bariatric surgery or weight loss surgery. What is bariatric surgery about, and what is it meant to accomplish, sir?
Bariatric surgery is a subspecialty of general surgery. We do surgery just like general surgeons, but we manipulate the gastrointestinal tract in such a way that it allows people to lose weight. They lose weight because their intake is limited, their appetite is decreased, and the amount of absorption is decreased. So 3 procedures occur at the same time when we do this surgery: decreasing the intake, decreasing the absorption, and decreasing the desire for food. When you have all of this working based on the operations we perform, then the patient has a net loss of caloric intake. That means a patient who normally would be taking about 3,000 calories is on about 700 to 800 calories a day. And with that, the patient loses weight.
Thank you, studio audience. Dr. Fobi, the perception, wrongly or rightly, is that more women come for bariatric surgery. Is the perception, again, right, or it's wrong? If it's right, why is that so?
More women seek bariatric surgery. As a matter of fact, the ratio is 4-to-1. So anywhere from 70 to 80% of those who have bariatric surgeries are women. The reason is women are more cognizant of their health problems. Men are more stoic. Men only go for medical treatment when matters are beyond control, whereas women are more apt to seek attention for their medical problems before it gets too worse.
There are people who think that women go for or come to see you because maybe there's a wedding coming up. In other words, they're coming for your procedure, for the procedure you perform on them, as or driven by cosmetic desire. Is this assessment correct, sir?
Well, let me put this in perspective. We are in a society where weight is a taboo. Being overweight, people are prejudiced against people who are overweight. And whereas the problem of obesity is a medical problem, unfortunately, society looks at it as a psychosocial problem, which it is not. So quite a few of the people that come is because of the psychosocial prejudice. They're suffering from the problem of obesity. But that is due to the fact that people perceive obesity as a problem that can easily be corrected by the person who is obese. Whereas obesity is a medical problem. To be obese, you have to have a certain amount of genetic predisposition. You all know a friend who is skinny and can eat all they want to and not gain weight. And I'm sure you also have friends who are overweight and they go on a diet and they're still gaining weight. That is because the genetic component of the obesity is so strong. And the society doesn't accept that. And so one of the things we do when we offer surgery is to educate the people who come to have surgery that it is not their fault that they are overweight. It is not their abnormal eating habits. It's because they have a predisposed genetic makeup that results in them being overweight. And therefore, they should not consider it a psychological impediment. Unfortunately, we cannot change the perspective of society, particularly in the Western society where skinny is thought to be much appreciated. But there are other cultures where being overweight is well appreciated. So a certain amount of overweight causes medical problems, and too much skinniness causes medical problems. Go ahead.
When you say that this is a medical problem, but oftentimes people are left to think or made to think that it's a problem to be corrected by them, the patients. You're not suggesting that weight loss experts, those who advocate for diet and exercise, they are wrong, are they?
No, they are not wrong. But if you understand that is a genetic problem and a patient has a predisposed condition to have that problem, then weight loss programs that exist can only be effective if they are carried out consistently and throughout the life of the patient, which is much easier said than done. So if you're going to put someone on a diet or an exercise regimen, the patient will lose weight. And if they follow what you do from the time you instruct them to. But the minute they stop, the weight comes back. That's what we call weight recidivism, because the body has what is called a hemostatic status, a status where the body comes in and stays where it is. So if you have a genetic makeup, you can only alter it so much. The other way for me to explain it to you is take a white person who goes to Africa and is under the sun. During the time when they're under the sun, the color of their skin changes. But their genetic is to have a white skin. The minute they leave the sunshine and come back to the temperate zone, the change goes back. The same thing happens with weight. So as long as you continue doing what the weight loss experts tell you to do and you do it consistently, you're going to maintain the weight. But all studies show that less than 5%, as a matter of fact, more like 1% of the people who try to lose weight and maintain it are able to do so beyond 2 or 3 years.
You are watching Voices of Africa at Chat Night, and my expert this week is world-class bariatric surgeon, Professor Mathias Fobi. You talk about obesity. What are the things that lead to obesity, and at what point would an obese person consider Dr. Mathias Fobi to be her answer or his answer?
Well, obesity is graded. We talk about normal weight. We talk about people who are overweight. Then we talk about people who are obese. And we use the term morbid obesity for those who have the obesity and they already have medical problems. A certain amount of overweight is healthy because it allows you to deal with situations where you go through stress or famine or any infection or disease. You can allow for about 10 to 15 pound weight loss and then get back to normal. But when you get beyond that point where your weight, we use the word BMI, body mass index. When your body mass index begins to get beyond 25 and approaching 30, you start approaching what we call obesity. That means the weight is becoming a problem itself. So when you get that overweight, you start having problems. The problems are multifactorial. You have problems with all parts of your body, depending on the extent of your obesity. You can have severe headaches because of what we call pseudotumor cerebri, pressure inside your brains. You can have joint problems, back problems. Then you start having other things like hypertension, diabetes, cardiovascular disease, and the whole body can be affected by obesity. As most of you know, with the COVID infection, most of the people who died were severely overweight people, and most of them had obesity as their comorbid condition. So obesity, when it gets to a point where your BMI is 30 and above, then you're dealing with where it is a morbidity and you should treat it.
Thank you, Dr. Forbin. In your practice, do you deal more? What age group are you talking about when you talk about obesity that needs your surgical procedure?
Well,
what's been the youngest age that you've operated on?
Well, when I was in India, we operated on a 6-year-old. So, but people have operated on people a lot less than that. But I've operated on people who are as young as 6 years old and as old as 81 years old. It is a medical problem. So age is not a factor. If you have a medical problem, irrespective of your age, we should treat you. Those who have obesity to the extent that they have comorbid conditions. When I say comorbid, that means that the obesity begins to affect their life and they need treatment, and they've tried non-surgical treatment. That means diet pills, lifestyle changes, and they have not been successful, and we consider them candidates for surgery. We'll offer them surgery, but we're going to make sure they can have surgery safely before we can offer them. And so before you have surgery, we have to do a lot of workup to make sure that you are physiologically stable to have surgery, just like any other surgery. So there's no age limitation. We have a variety of operations. So right now we are able to tailor what surgery we give you based on your medical condition. So if you come in and you're just mildly obese, there's some procedures we'll give you. And if you're real big, like some of the people I did who were 500 and 600 pounds, we have to stage your surgery, do one surgery, and when you lose weight, we do another, and then another surgery after that. So it's like a medical condition. We treat you based on your extent of obesity.
Tell me, Dr. Forbin, when you say we, how many surgeons of your caliber get to operate on somebody who is about 500, 700 pounds?
Well, yes, I'm one of those who were pioneers in the field. I got in the field in 1974. The first bariatric surgery documented in the United States was done around 1954. So I got in about 20 years. When we first started, there was just a handful of us in the United States who were doing obesity, and then there were a few more in the world. I think the first couple of meetings which I had in Los Angeles, we used to have around 100 people. But right now, there is an American Society of Bariatric and Metabolic Surgery that has about 1,800 surgeons who can do this operation in America. And worldwide, there are about 5,000 surgeons who can do this surgery for obesity. So it has grown over the last 40 years exponentially. As long as people have realized that surgery is the most effective treatment for severe obesity, there are more and more surgeons doing procedures. And right now, the number is going to increase exponentially, especially since gastroenterologists are getting involved now, doing procedures where they can reduce your stomach size through an endoscope going through your mouth. Even though it's not as effective, it is effective. It loses enough weight to reduce your mobility.
Walk me through the process.
Yes.
Somebody comes to your office, you determine that surgery is what you need to do. Walk me through the process. What is it that you do on that person?
Well, I'll walk you through, but we are in the internet generation. Most people, by the time they've come, they've Googled everything and they know what to do and what we're going to do. But basically, when a patient comes in, the first thing we do, we determine their BMI, which is called body mass index. It's a calculation which we make by taking the weight of the patient and dividing it over the height of the patient, whether kilograms versus over meters or pounds over feet and inches. So if we find out that you have a BMI above 30, then you're considered obese. If you have a BMI above 35, then you have obesity type 2, and at that time, surgery is indicated. Now we do a complete evaluation. Once we determine that you're a candidate for surgery, you are seen by a nutritionist who looks at your eating habits and sees whether there are any things that can be done to help you lose the weight without having to undergo surgery. We also have psychosocial people that evaluate the patients. And if we find that there are any things we can do to help you lose the weight, either with medication, exercise, or lifestyle changes, we encourage you to try that for a period of time. A certain number of patients, very few are successful, about 5 to 10% are successful, and they don't end up having surgery. Those who are not successful then end up coming for surgery. When they do come, then we do a complete panel of tests, blood work, and endocrine evaluation to determine the type of complications they have from the obesity, whether they have diabetes, whether they have hypertension, sleep apnea. People who get overweight stop breathing in their sleep. We call that sleep apnea. Whether they have GERD, which is when you say you have heartburns, whether they have gallbladder disease, they have arthritis, joint problems, cardiovascular problems. And at a center like mine, where we use a multi-specialty approach, the patients are seen by various specialists. They're seen by a pulmonary consultant who checks their lungs. We're seen by a cardiologist who checks their cardiovascular system. They're also seen by an ophthalmologist because people who get overweight start having problems with their eyes. And they are seen by an endocrinologist because of the diabetic predisposition of being overweight. And then also by a nephrologist because people who are overweight tend to have kidney problems because of the arteriosclerosis. And by the time you finish seeing all these consultants, in addition to a nutritionist, we know your status and we know whether we can help you. Once we know that we can help you, then we start discussing with you the various types of surgical procedures we have. At this time, there's a range of procedures that goes from less invasive to severely invasive surgery. I'm not going to be too technical, but I'll say you start with what we call endoscopic sleeve gastroplasty, where you can go through the mouth and make the stomach small. We normally reserve this for patients who have a BMI of about 27 to 32, and they can lose about 10 to 15 kgs and will do well. And these are people who can afford it and whom we think they can follow the instructions of eating slowly and small quantities. Then the next stage of operation is what we call the sleeve gastrectomy, which is also less invasive. And then there's the gastric bypass, and then we move on to the biliopathic diversion and other surgeries. So there are a gradation of operations that we perform depending on the patient. The patient is advised, and the patient participates in deciding what operation they're going to have. So once they decide on that, then they are seen by a doctor who is going to put them to sleep, the anesthesiologist, and then the patient is scheduled for admission. In India, we admit them the day before, but right now in the United States, most people are admitted the morning of the surgery, have the surgery that day, and at most stay in the hospital for 1 day, at most 2, and then they are discharged depending on the operation they have. And they have to come back for regular follow-up.
Typically, how long does such a surgery go on, sir? I mean, the invasive surgery that you're talking about.
Well, it depends on the expertise of the surgeon, the hospital where the surgeon practices, and the team. In a hospital like where I am consulting now in India, we have a multidisciplinary team. These are people who only work on patients who have obesity. And there are many centers like that in the United States presently. You can come and get the surgery normally. It lasts nothing more than an hour from the time you get into the operating room to the time you get out, depending on the team. If you have a multi-special team where the people are used to doing this type of surgery, we know the operation step by step. Obviously, you have to do your research when you choose a doctor or a center where the surgery is done, and get to know how many operations the patients do, the doctor has done. In any surgery, the outcome depends on 2 factors: the training of the surgeon and the volume of work that surgeon does. So if you go to a surgeon who does a lot of surgery at a center where a lot of surgery is done, they have better expertise, they have better results. The same thing with bariatric surgery.
You are watching Voices of Africa at Chat Night. My guest this week is international reputable bariatric surgery surgeon, Dr. Professor Mathias Fobi. I will be bringing Professor Mathias Fobi back on the platform for further questioning. Time for us to go have a transition while he sips a glass of water. This broadcast is being aired live now on YouTube. Watch this. You will love what you're about to see. You are watching Chat Night Africa. You just watched the Subi sensations of Old Town Bamenda, Cameroon. These guys have been performing in different Hispanic countries, European countries, and African countries. They are hard to beat. They're tough to beat. They will be performing live from Bamenda sometime soon at Chat Night Africa. Ladies and gentlemen, join me again in welcoming Professor Mathias Fobi on the platform.
Thank you.
Dr. Fobi, you acknowledge that there are so many people doing this bariatric surgery in the United States and all over the world. Tell me, what is it that shocked you to such international acclaim?
Well, I'll tell you, it's serendipity. You can understand I didn't leave Africa and come to America to solve obesity problem, which when I left Africa was not a problem. And even when I started doing surgery, we did not look at this problem as a medical problem. As when I was in medical school, we were ignorant as to what obesity was and its complications. And it was in 1954, like I told you, that some surgeons found out that they could treat this problem medically and surgically. We have since learned that obesity is a medical problem and not a problem due to psychosocial consequences. How did I get into it? It was by serendipity. I was at King Drew Medical Center in Los Angeles under the auspices of Dr. Joseph Alexander, who was my chairman. And we had a patient that had had this operation. It was called the intestinal bypass. And she had complications. So I was challenged by Dr. Alexander to take care of this patient. To make a long story short, I found out that the procedure the patient had complications, and we could correct these complications by taking down the operation the patient had and doing another operation called the gastric bypass. So we took down the intestinal bypass to do the gastric bypass. I did that as a senior resident in training. I was lucky to have consultation from Dr. Ed Mason, the father of bariatric surgery, who sent me directions to me and my chairman on what was called it was a fax machine at that time, but it was called telex. And he gave us instructions as to what to do. So here I was, after having gone to Cameroon and spent time at the Bolowa Hospital and talking to Dr. Anamango and Dr. Mona and planning to go back to Cameroon. Here I was exposed to a problem that I didn't really know much about. And when I took care of this woman and took down her intestinal bypass and gave her what was called a gastric bypass, she was very happy because she had gone to UCLA, USC, and everybody had planned to take down her operation. For you to appreciate the problem of obesity, this lady used to be 347 pounds. And when she came to me, she was 139 pounds. She had complications of frequent diarrhea, joint problems, electrolyte imbalance. When she was offered to have her surgery reversed, she said she would rather die than have the surgery reversed, because reversing the intestinal bypass meant that she would regain the weight back to 300 plus pounds, and she didn't want to do that. I was amazed that somebody was willing to die with all the complications she had. And so when I reversed her and she did well, she referred a couple of patients to me. All of them had had intestinal bypass. Most of them were celebrities in Hollywood, since I was in Los Angeles. And I was able to take down the intestinal bypass and do the gastric bypass, and they did well. This was very intriguing because I realized that I was able to solve a problem that most people did not know how to deal with. There were few surgeons in the United States, like I said, less than 100 who were doing gastric bypass at that time. So we started a division in my hospital for treating obesity. And by 1981, I had become so intrigued by my results that I started the Center for Surgical Treatment of Obesity in Los Angeles. And that, all the rest of it is history. So I've not gone back to Cameroon. I've not done any general surgery anymore. And my life has become treating people who are severely overweight. We've treated people as big as 800 pounds and as little as 200 pounds. We've treated people as young as 6 years old and as old as 81 years old. We treat patients from all parts of the world. And this problem is not really limited to the United States. We're having this problem now in Africa, but it's different because most of the people who are getting overweight in Africa right now are the affluent ones who can afford the Western food. See, when you have the genetic disposition, you have to have the food. So if you have the genetic predisposition, you don't have the food, you're not just going to gain weight just because you have the genetics. So we have the genetic predisposition in the African community, and many people who come here and start eating the American food have a tendency to put on weight. That's why I have quite a few of our people who are obese and they have complications now of diabetes, hypertension, and other problems because of the obesity.
Dr.
But that is how I
Fobi,
became involved.
Dr. Fobi, you have been a very successful, by all accounts, very successful bariatric surgeon, but others haven't been so lucky. How has weight loss, or how could weight loss go wrong or fail in some instances?
Oh, weight loss surgery is like any other operation. When you do an operation, there could be complications. There are complications that are due to the ineptness of the surgeon or the medical center or the hospital where you practice. And then there are complications that are inherent in the procedure. That means no matter how good you are, that procedure has certain complications that will occur. The one thing you can minimize is the complications, or are the complications that are due to lack of expertise, having inadequate supply by the medical center, or having inadequate support. And so what I did when I started doing this, I was the first one to set up what was called a multidisciplinary approach. And I will say this very frankly, I had to do that because coming to America, I learned very early that as a Black person, you could not go out there and play on a level field. You had to do 100 plus 100 times what the average person did in order to get success and be accepted. So I did not go into this field trying to take it on by myself. So I had all the experts whom I thought I needed to be part of my program. And so I was one of the few that had what was called a multidisciplinary team, which included a nutritionist, a psychiatrist, a psychologist, a lung specialist, a cardiac specialist, and I used a special team of anesthesiologists to work with me. And these consultants were available to me at all times. And by doing this, we were able to minimize complications that were due to doing the operations. However, there's some complications that are due to the particular operation you have, and we can only control that by educating the patient so the patient follows certain instructions, and by making sure the patient comes back for frequent follow-up, where they are seen by a nutritionist, a social worker, and a patient counselor, and we monitor the patient's blood work to make sure those abnormalities do not go to a point where they're unbearable. So by doing that, we are able to minimize the complication. I'll tell you, we've come a long way. This operation used to entail bringing people to the hospital 1 week before surgery, doing all the workup in the hospital, and then doing the operation, keeping them in the intensive care unit with arterial lines and various tubes all over the place, and then waiting till they could eat before you send them home. So the hospital stay used to average anywhere from 2 weeks to 3 weeks. With the advent of what we call laparoscopic surgery, we're now able to admit patients the morning of the operation, and in most cases send them home after 24 hours, and they can walk and do very well. So the expertise in the field has become so good that the morbidity is very low. When I started doing this operation, the death rate was somewhere around 4%, but right now it is more like 0.1%.
I was going to ask you, Doc,
Yeah.
you, when I was going to do major back surgery,
Yeah.
The neurologist threw the textbook in my face.
Yes.
And he was very blunt that, look, Divine, you could become impotent after the surgery, or you could end up in a wheelchair. Thank God none of those things happened,
Yep.
because then I would have just gone to perhaps a seminary. But the question I want to ask you, sir, is what are some of the things, the complications that could arise during the process of bariatric surgery that you would want patients to know?
Well, in the hospital, the things that can occur are simple. You can end up bleeding. You can have an infection. You can have what we call a leak. That means the juice from the intestinal tract leaks into the abdominal wall. You can have a blood clot because you're lying down in that operating room for too long, or lying around the hospital for too long, and you get a blood clot in your legs. We call it deep venous thrombosis. Or you can have the blood clot go to your lungs, where you have what we call a pulmonary embolism. So those are the main things: infection, blood clots, and bleeding. Those are the common things that can happen in the hospital. The rest of them can happen later. And those are things like electrolyte imbalance, losing too much weight, having an obstruction, having a hernia, and all of those things we can manage.
We'll talk about post-surgical care. The question somebody just sent to me by text. By the way, my phone line now is open. If you have a question about bariatric surgery, you can dial the number 240-603-7367. Let me repeat, 240-603-7367. If you are overseas and you want to dial via WhatsApp, you do 001 first. Doctor, here is the question somebody just sent me by text. Have you had situations that patients did the bariatric surgery but reverted to you later because it just didn't solve the problem? It got them to square one. What got them to doing the surgery in the first place?
Yes, you're dealing with human beings. We have done surgery in patients who had the surgery and lost the weight and were very unhappy. And so we have had to reverse the surgery, which we rarely do, but that has occurred. We have had patients who had surgery and developed complications from the surgery and have had a very miserable life and are living with those complications. That's just part of the parcel. For instance, one of the common procedures we do is called a gastric bypass, where you move the small bowel and bring it up to a small pouch. In this surgery, there's a possibility of something called an internal hernia. And when you have that hernia, you can end up having bowel that twists around itself and the bowel dies. And you have to go in and take out most of the bowel of the patients. We don't want to have that happen. So we do things to prevent it, but it does occur in a very small percentage of patients. And a patient like that, when they lose a lot of their bowel, they might have to be on IV therapy for the rest of their lives. So there are things that can occur. And when you come and have surgery, we discuss all these possibilities with you. You know, we, the surgeons, don't want you to have any problems, particularly in the United States with the medical legal consequences. So we do all we can to minimize those problems, but they do occur, even in the best of hands. And even with me, I've had patients who died from complications of having bariatric surgery. I did all I could, but I couldn't save them.
Critics of bariatric surgery, Professor Fobi, describe it as a band-aid on a lifelong problem.
Yeah, bariatric surgery is like any other operations. When we surgeons offer you a surgical procedure, we are almost 99.9% confident that it will work. But in about 1% of the case, it doesn't. So when that happens, we try to do what we can, what we call remedial procedures. So bariatric surgery is the same way. We do the operation, and depending on the particular operation, there's a certain amount of success rate. Success is determined by so many variables: how much weight you lose, whether you're having any complications, whether you've lost too much weight, whether you've not lost enough weight. So we have to intervene whenever any of this goes wrong. But there is no guarantee when you have the surgery that is going to work. It is like any other operations. The surgeons offer you the surgery because they have a high assurance that it's going to work for you. But in the 2 or 3% to 5% of the cases, it may not work and something else might need to be done.
Again, the phone lines are open 240-603-7367, 240-603-7367. The phone is in my hand. You can dial and ask your question in real time, and Dr. Mathias Fobi will answer. I think before the technical problem which we rectified, I was asking you the question. There are people who say that bariatric surgery, or who describe bariatric surgery as a band-aid on a lifelong problem. Is there some truth to that assessment, sir?
Yes, people make that statement, and it's very common because of the wrong perception that obesity is not a medical problem and that it is a psychosocial problem. Understand that
Yes, it looks like you
resolution.
Yes, sir. Go
Can
ahead.
you hear me?
Yes, I hear you.
Yes. So it's not a band-aid. It works. I personally would tell you that I had bariatric surgery, and some of you know I had a little bit of weight, but I did not have it because of the weight. I had it because I had type 2 diabetes. And the gastric bypass procedure, the Fobi pouch procedure that I do, treats patients with diabetes. So at the age of 65 in 2011, I went ahead and had one of my doctors do the operation on me. And since then, my diabetes has been controlled. I lost about 40 pounds, which I've maintained over the last 10 years. So it is not a band-aid. It works. Those of you who know me and have been following me, you know people like Jennifer Holliday, who had this surgery. I mentioned some of the celebrities whom you might know because they have been on television with me and talked about it. She had this surgery in 1989. She lost the weight and she's maintaining it. Some of you know Randy Jackson, who had this surgery about 15 years ago. He is American star. He lost it, and if you see him, he's maintaining it. It's not a band-aid. It works. And I know a couple of Cameroonians who've come to me and have had the surgery, but I cannot talk about them except they've gone on television and accepted that they had it. But the names I'm giving you are names of people who have gone on television and say, yes, they had the surgery. It's not a band-aid. It is a necessary operation. It is the only effective solution that will help a lot of people. Like I said, less than 5% of people can lose weight and maintain it on their own. And people, when they do that, they normally write a book about it. The other 95% of people cannot lose weight and keep it off. The other 95% will lose the weight. Definitely, you can lose 100 pounds. But after 1 or 2 years, you regain that weight and more. I've always told people I have a simple mechanism to get you to lose weight. I can send you to the Sahara Desert in Africa for about 11 months. And during that period, you're going to lose weight. But the minute you fly over the Atlantic Ocean and in America and smell the hamburger and the hot dog, the weight is going to come right back. So surgery is the only effective long-term option. Non-surgical treatment works, but the patient has to do what they've done to lose weight and keep doing it for the rest of their lives. The minute they stop doing it, the weight will come back. So I'm not against non-surgical treatment. I'm just saying that the probability to keep doing it on your own is so poor, the probability is so low that surgery is the best choice you have. And I have patients who've had surgery and they've maintained the weight for 30 years and they're doing very well. Some people who have surgery might gain weight, No, surgery is not guaranteed. With time, you're going to gain some weight because human beings know how to avoid whatever it does. It's like you find you can't eat, so you eat 4 or 5 times a day, or the surgery limits what you can eat, so you choose something that you can eat, or you take high caloric input. That's why surgery has to go along with counseling from the nutritionist and regular follow-up from your surgeon.
I was going to ask you this question. After bariatric surgery, what is the patient, say it went successfully, what is the patient required to do to maintain the weight?
Number one, the surgery in and of itself restricts how much food the patient can take. And the operations we do now, particularly the gastric bypass, causes what we call anorexia. It decreases the secretion of a hormone called ghrelin. And so your desire to eat decreases. It alters your senses for food. You find that certain foods are not as delicious and as nice tasting. So because of that, the amount of calorie you take is less than 1,000 calories after about 6 months. And the thing which is good about it, you keep taking less than 1,000 calories for almost the rest of your life. And that's why you maintain the weight. Surgery decreases your caloric intake and it forces you to stay at that limited caloric intake for the duration as you have the surgery. And since surgery is permanent, that means your weight loss will be permanent. With time, you might adjust and gain some weight, but most times, if the patients come back for counseling, which they are supposed to, when you have surgery, you're supposed to see your surgeons on a regular follow-up. You're supposed to keep in touch with the nutritionist. You have to follow some instructions we give you. There are vitamins and certain supplements you have to take. And if you follow those things strictly, you'll do very well. It's like buying a car. When you buy a car and you maintain it, it will last long. But if you drive it without taking it for checkup, then you have a breakdown and things go wrong and you blame the car.
Professor Fobi, when is bariatric surgery? He dropped off the line. These things are to be expected. You are watching Chat Night Africa. You're watching Voices of Africa at Chat Night Africa. We are waiting for Professor Fobi to come back right in, but time for us to get probably a little transition. Watch this. This is Chat Night Africa, and you are watching Voices of Africa. Here is once more Professor Fobi on the platform.
Thank you.
Professor Fobi, I honestly, you are a walking dictionary in matters of bariatric surgery. The question I have next for you is, when is bariatric surgery the more appropriate step to take instead of other methods of weight loss?
That is a decision the patient has to make. There are modalities which will help the patient lose weight. Changing their lifestyle, choosing the right foods, combined with activity, exercise on a regular basis, and in some cases, the use of medication that will suppress the appetite. And if you do that under the supervision of an expert, you may be able to lose that weight and keep it off. However, like I said, the experience and multiple studies have shown that 95% of those who do that stop doing it and regain the weight, and at that time, surgery will be the choice. So when we get a patient who has tried non-surgical intervention, which is changing their lifestyle, decreasing their calorie intake voluntarily, and using pharmacologic agents, and they are morbidly obese, and particularly the patients who have complications from the obesity, like diabetes, hypertension, pseudotumor cerebri, sleep apnea, arthritis, social problems, which doesn't allow them to shop from the regular store or to ambulate or to climb stairs. The list goes on. When the patient gets to that point, they will come in for surgical intervention, and we'll discuss the ramifications of obesity. I'll tell you, when you take somebody who is severely overweight, who can barely walk, who has diabetes and has sleep apnea, and you do one of these bariatric procedures on them, and they lose 20, 30, 40, 50 kilograms and keep it off. The diabetes is controlled, they have resolution of the high blood pressure, they sleep at night without snoring, they're able to walk, they're able to climb stairs, they're able to shop, and their social life is enhanced.
Dr. Fobi, we could be here till tomorrow morning talking about bariatric surgery, especially as you are cautious in the subject. Is there something which you think patients or the general public, the wider public, should know about bariatric surgery that I haven't raised in my questions?
Yes, I mean, you've raised most of it, but I would like to summarize that bariatric surgery is a necessary and the most effective modality presently available for those who suffer from severe obesity. There are different types of bariatric operations, and it is up to the patient to investigate the operations, investigate the doctors who do the operations when they decide to undergo one of these procedures. But I'll tell you, if you do that and you get the right procedure that meets your condition, you'll be a very happy person. My experience has been that for more than the 12, 13,000 patients I operated upon during my lifetime, many of them tell me the day they had the operation was when they started their life. They consider that a time when they were born again. They could shop in regular shops, they could climb upstairs, they could sit down and cross their legs. They were not the ones sitting at home to babysit for their brothers and sisters because they could not go out to the parties and move around. And nobody noticed them when they came into a room. These are all psychological consequences of being overweight. You see, when you're overweight and you walk into a room, everybody notices you. But when you're normal size, you're just another person and nobody notices you. When you're overweight and you go to a cafeteria and take a plate of food, everybody looks at your plate to see how much food you have on your plate, as if you're not supposed to eat. Those are all activities that are due to the ignorance and the fact that people think people who are overweight because of their own problems. No, obesity is not a psychosocial problem. It's a genetically mediated medical condition that at this time is best treated by surgical intervention. Thank you.
Here is a question from lawyer Aneneba Akufo. Dr. Fobi, can you successfully follow a fasting regimen without any cravings after bariatric surgery?
The two don't go together. You can have, when you have bariatric surgery, one of the things it does, it decreases your food craving. If you have a gastric bypass, for instance, I use myself as an example. I have been anorexic for the last 10 years. I don't have desire for too much food. I don't have desire for fried foods. So that is one of the beauty about having a surgical procedure that decreases your desire for food and decreases your desire for fatty foods. You can follow fasting, but when you have surgery, we don't recommend that you follow fasting. As a matter of fact, when you have surgery, we recommend that you eat small quantities of food at regular intervals, and you try to eat a balanced diet so you get the vegetables and the vitamins that are necessary for your constituent. So we don't want you to go fasting after you have surgery. Fasting is something you do when you don't want to have surgery. But when you fast, you should do that under medical supervision, and you should have your blood work monitored so you don't suffer from any deprivation.
You are watching Voices of Africa live from Washington, D.C. metropolitan area. Dr. Fobi, before we close the show today, do you have a last word? I'll give you 2 minutes for that, sir.
Well, I just want to thank you. Sorry, I did not know about your program till you contacted me, and I have had a chance to go back and look at some of the previous interviews you've had. I think you are doing an excellent job for African community, for Cameroonians in particular. I think you're one of those we have to be proud of. I always like to see a fellow Cameroonian who is doing well, like you do. And most of you who know me know that I like to encourage all of my fellow Cameroonians to do well, to be the best they can in the field. And when I run into somebody like you who is doing what you are, exposing our people to the necessary treatments, I think you're doing a great job. I want to thank you for asking me to be here. I am available. People can text or write to me if they have questions about bariatric surgery. As you know, right now, I am almost completely retired. I'm consulting remotely from my job in India. I returned back to the States because of the COVID condition, but I'm available by text or by email, and you have that on your program to answer questions. But I think if you have severe obesity and you have diabetes and you're having complications, you should consider bariatric surgery. Thank you very much.
That's how we wrap up the broadcast this week. I want to thank you, Dr. Fobi. You are a very busy person. You know, I've known your family for a long time, and I got a lot of requests from ladies especially. Hey, Divine, why don't you bring Dr. Fobi on Voices of Africa? We cannot thank you enough, sir, for so generously sharing your expertise and for making it so simple. I mean, everybody could just understand you. My worry was that when you bring a Mount Everest of bariatric surgery that you are, it might be a tough time having you go down to the level that everybody understands. But we're grateful to you, sir.
Thank you very much. Keep up the good work.
Thank you, sir. And I would like to thank all of the people who have contributed one way or the other for this platform to look the way it is. Dr. Fobi, 3 years ago, we started this on a cell phone. The drive was there, the skills were there, the resources were not much there. But because our friends were able to have what we have and we continue to improve. That's our mantra. We stop at nothing to make sure that the audiovisual quality of what you watch is up to standard. Thank you, sir.
Thank you.
You are welcome. Ladies and gentlemen, and that's where. But before we go, lots of you are celebrating your birthday today. Lots of people are celebrating their wedding anniversary. Here is what I have for you. Happy birthday to you. Happy birthday to you. Happy birthday to our friends. Happy birthday to you.
Hooray! Hooray! Hooray!
And it's on that note that we go. Thank you so much for watching. That has been Voices of Africa at Chat Night.
I'm coming to get down. I'm coming to dance, We're gonna dance, we're gonna get down, we're gonna party hardy. We're gonna boogie woogie, and when we jam, it's out of sight. This song right here, it's dynamite. I'm ready, I'm coming back.